It's time for my banner here on the AM show, but let me read a message that Elon sent, and that was when I was talking to the pastors. It says, well, I'm really inspired by seeing Pastor Ato on your screen, a man of God who I love to listen to on radio. Pastor, thank you for your good work. Thank you, Elon, for that message. I didn't share it earlier, but I did share it with Pastor Ato, so he knows how you feel about him. Thank you so much for sending in the message. Now, let's get on to our National Health Insurance Scheme report conversation that Sen Ghana has put together. My guest in studio, Mr. Adamu Mukaila, is Program Officer at SEND, and Mr. Frank Toblu is Executive Director of Health Insurance Service Providers Association. So good morning, gentlemen. Thank you for coming.
Good morning. Thank you very much.
Maybe let me start with you, Mr. Mukaila. Why did SEND decide to embark on this journey?
Yeah. In 2004, when the National Health Insurance was actually introduced, it was supposed to be a pro-poor policy which aimed at ensuring that the poor have access to health care. In 2010, SEN decided to assess the NHIS to see whether it's achieving its objective of ensuring that people have access to health care provision in the country. So in that assessment, we realized that the NHIS actually has increased access, but it has also exposes the challenges of the health delivery system, because it has actually increased access, and the health systems were not able to meet the demand, and therefore quality healthcare was actually compromised. Okay. So after that, we didn't just end there. When we come out with a report, we engage stakeholders. So our 30 engagement sessions were organized with the NHIS, both at the district, regional, and the national levels. And in that interaction, it came out that people were just saying, oh, we are not benefiting from this national health insurance. Is this national health insurance even a pro-poor? You are saying that it's a pro-poor policy, and yet the poor people are not benefiting. So in response to that, we decided to do a follow-up research to see who are those benefiting from the national health insurance. So that is the main reason why we came out with the second.
So that's what you've done now?
Yes, yes.
Okay.
Yes.
So I really want to ask who is benefiting, but maybe I can ask the association.
Yeah.
What's the state of the scheme as you see it now?
Presently, I think the scheme is having some challenges. We must all admit that. That is to say that currently the challenges that the scheme is facing is financing. That is one of the major challenges, because if it comes to the level of paying claims to the service providers and the funds are not readily available, it goes to do a whole lot of things. Sometimes you will agree with me that people get to the hospitals, the providers tend to demand cash for some of the services, because they also feel that it is important for them to have access to cash to enable them procure some medicines in one way or the other to continue to run the health insurance from time to time. You know, so
financing on whose parts?
I might say from the government. That is, if the fundings are made available to the National Health Insurance Scheme, obviously they will release it to the service providers as well.
So you know this issue is not new.
It isn't.
So how bad is the situation today?
The situation as we speak today, it's better than it used to be some time back. I must confess that, because presently hospitals are getting money at certain regular intervals, as against when sometimes back they have to wait for a longer period of time.
The ideal situation of 3 months, is that what is being experienced today, or we still owe more than 3 months?
Presently, it's still more than 3 months. You see, by law, as far as the LI is concerned, it's actually not supposed to be 3 months, but by consensus, we just agreeing to that 3 months. So I personally don't endorse the idea that there is a 3 months period of payment to the service providers. Ideally, the best is 1 month.
So how much are you owed now? How many months?
As I speak here, I'm unable to mention the exact amount owed the service providers nationwide, because I have not gathered data as I'm working
I don't want the exact, as in the figure in terms of the amount. You know, say 3 months, 4 months, 5 months.
Oh, I see. Now, come to that, I think we are in 4 months.
4 months.
Yes, 4
okay.
months. Yeah.
That's better than the 8 months
better
we used to experience.
Yeah.
So who is enjoying the service?
Yeah, Ghanaians in general, but specifically the rich and not the poor. Why are we saying the rich and not the poor? The policy itself is a pro-poor policy, which means that if I don't even have money to register, I should be able to benefit once I'm considered as a poor person. And the definition of the poor by the NHIS is the cause of the poor not benefiting.
Okay.
Yeah.
So what's the definition,
For
so
instance,
we'll all be on the same page?
In Ghana here, it will be very difficult to get a sane person who have no permanent place of abode. You get it? Even some madmen have permanent place of abode. So if somebody is poor and that person has a permanent place of abode, according to Act 650, he is not considered as a poor person to be registered under the indigent category. The person should not have employment. He should be unemployed. And he shouldn't have an identifiable source of income. And also, he shouldn't have a known source of support from somebody. Or he shouldn't even be staying with somebody who is employed and has a fixed place of abode. So if you define the indigent in this way, then it's problematic when it comes to identifying those people. So if you go by the NHIS definition, for instance, in the Upper West region, if you take the Ghana Statistical Service definition, which is based on expenditure, consumption expenditure, which says that if somebody the whole year is not able to spend 792 cedis a year, that person is considered as what? Extreme poor. It means that if that person devotes all his income to just feeding himself, he will not be able to do that the whole year. So these are the definitions by Ghana Statistical Service. And if you take that number in the Upper West, for instance, 45% of the population are below the poverty line, are extreme poor. But our research findings indicate that only 14% of that population has been registered under the indigent category.
Do we know why?
Yeah, like I said, it's the definition of who the poor is by the NHIS.
So the definition is restricting the others from getting onto the scheme.
Exactly. If you go strictly by the definition, then it's only the madman that some of them, not even all of them, can be registered as indigents. So there's a need for us to look at the definition. Is it not better for us to look at the Ghana Statistical Service definition of the poor? And according to them, there are about 2.2 million Ghanaians who are considered as extreme poor. If they spend all their money to buy food, they will not be able
to take care of their health.
Yes. So it's better we collaborate with Ghana Statistical Service, NHIS, identify these people, and then register them as poor people.
Are they easily identifiable?
Yes. Though? If we collaborate with Ghana Statistical, like I said, 45% of them is in the Upper West region, 21% of them is in the Upper East region. So we know where they are. So if the NHIS collaborate well with Ghana Statistical Service, and then the Department of Social Welfare, you see the Act 852 have now taken the responsibility of identifying who is poor, and then is now taking it from the NHIS and giving it to the Department of Social Welfare, so that they can now use their own meters to identify the poor. That is a very good step. But we are also urging that they should go a step further by involving the Ghana Statistical Service to identify the core poor. Not even only the core poor, but the poor itself. Currently, the poor population is about 6.4 million in Ghana. That is those who can even meet their daily requirement. That is, if you are spending 1,314 a year, that amount to $1.8 a day, then it means that you are considered as poor.
If you are spending
1,340
a year,
as against that is the
then
upper,
you're considered
as poor.
Okay.
But the extreme poor is where your income is below the 792 Ghana cedis. So those cannot even meet their daily requirements
But
in terms of
from
food
these
production.
statistics that you're giving,
Yes.
I'm thinking that the poor and the pro-poor are all supposed to be covered.
Exactly. So that's what we are looking at. So if you are looking at that, the figure is big. We are looking at 6.4 million Ghanaians who should be registered as poor on the NHIS.
So let me come to Mr. Toblu. Do you get the sense in the points that is being made here? And also, who do you think are the recipients of the scheme? Because you provide the service.
Sure.
So you know those who come to you.
Exactly. Now, what I have to say here is, you see, I just want to make some correction to the Act 650. It has actually been repealed. In other words, revised to
so there's been some amendments.
Yeah, there has been some amendment to the Act 650 with regards to the definition of the poor. So I think we'll be discussing that as we move along. Now, I might say that those who are presently benefiting more from the health insurance scheme as we speak today, currently are the rich in the society, the middle and then the upper class. They are benefiting because they have uploaded their financial burden with regards to the health to the national health insurance. Now, when you go to places where you know apparently this person can pay to receive services, would now go to the national health insurance scheme. That is the situation. If you go to the hospitals, you could see people who are in a better position to pay for certain services would bring the health insurance card.
Was that supposed to be the understanding? That if you can afford, then don't sign on to it?
No, that is not it. I do not fault them for that, because each and every Ghanaian is supposed to be on the health insurance. That is number one thing. But you see, we're also looking at the sustainability of the national health insurance scheme. Now, the flat rate that is being charged with regards to premium, you know, it's neither here nor there. Because if you look at the premium being charged today by the national health insurance scheme, average of 20 Ghana cedis to 22 cedis. Okay. Now, you realize that when people come to the hospital, and by the time you finish with them, let's take malaria for example, you are almost getting to 60 Ghana cedis per person. So obviously you are having a difference of financing gap of 40 Ghana cedis.
If you use 20.
Per person. So multiply that by the number of people who visit the hospitals across the country. Now, when you put that figure together, as at October this year, we have 258 million financing gap. That means that is supposed to be money made available to the National Health Insurance Scheme to pay claims on behalf of people nationwide. That is the financing gap. Quite apart from...
You said 200 and what?
58 million Ghana cedis. That is as at October today. So you realize that there is a whole lot of difficulty when it comes to the assessing of the health insurance in terms of financing. So basically, like I said, the rich are benefiting more than the poor.
Shouldn't we have known all these?
Yeah, we are very much aware. You see, I realize that currently the National Health Insurance Scheme is doing some amount of a campaign to get everybody on board. But targeting the very poor, as my brother is saying, is another ball game altogether. They have to stress on the more. That is what they have to do.
But what is important to do now? Is it getting everybody on board or targeting those who really need the support? Because targeting everybody means a lot more people would be paying, at least even if it is 20 cedis or 22 cedis. But targeting the very poor means they are not paying at all.
They are not paying. The only person who is not even paying is a poor person. If you take those ages below 18, they still have to pay for the registration fee, even though they are not paying premium. And those above 70, they also have to pay for the registration fee and not the premium. So the only people who are not paying for the registration and the premium is the indigent, the very poor people.
All right.
Yeah, like he was saying, if you look at...
Let me allow him to learn and then...
yeah, and I think I just want to make a point with regards to what he's saying. You also realize that the health insurance scheme as an institution is also having difficulty with regards to the too many exemption groups that it has presently. Because if that continues, it's going to create a lot of problems. That is one. presently we have under 18 not paying for not paying premium.
Isn't that fair?
You see, when you look at the MDG 4 and 5, it talks more about children under 5 and then the pregnant women. You understand? Now, but then if we critically look at this, I would go to suggest that those above 5 should be made to pay. Because if truly we are talking about sustaining the national health insurance scheme in this country, and then considering the statistics I give you, with the financing gap of paying a premium of 20 cedis as against claims of 70 or 60 thereabout, you realize that if we continue on that path with a greater number of people coming on board, it means that if you multiply that by the financing gap that we have, then we are not going anywhere.
So you think those above 5?
Those above 5
should be made to pay the premium.
Yes, I mean at least a reduced premium. If you look at this number, these are people who are going to school. These are school-going.
But they don't earn money.
They don't earn money. I must agree to that. But then, what I would suggest, you see, we are looking at the sustainability, because if not for anything at all, the National Health Insurance Scheme is helping. I must admit that. So the bottom line is, how do we sustain it? So we are all looking for ways and means of making it sustainable. So that is where I'm suggesting that if we use the school system, okay, the school system that, you know, at the end of every term we pay school fees, okay? So this would be juxtaposed onto the bills that the kids...
Would that be fair? Because not every parent is using the NHIS. Some people have private insurance.
Yes, you see, the law of the National Health Insurance suggests that anybody who gets onto any other private health insurance scheme should have the National Health Insurance. That is the part of the law. So before
I don't get it.
What I'm trying to say is that before you get, let's say, go to a private health insurance, for example, Nationwide Mutual Health, okay, if you want to sign on over there, you should be able to have or produce the National Health Insurance card.
What's the point?
You see, the law is such that this is a program designed for the Ghanaians, the nationals of this country. So it's more or less becoming mandatory by virtue of the law.
But what's the point in signing on to a service that I'm not going to use? And that's not more effective than the private one that I have. I disagree, and I'm sure a lot of Ghanaians would disagree to that. And what's the point in going to get an NHIS card? Mind you, in some places, people say you have to either keep going and going and going before you even get yourself registered and get that card. Why should we go through that hassle when we are not going to be using it?
Well, that is the position of the law.
But that's, I guess maybe this is another argument for another day. But you wanted to say something.
Yeah,
you wanted to come in, and there's a certain recommendation that you're also making with regards to the LEAP program.
Yes. Yeah, we just didn't look at the National Health Insurance alone, but we look at other intervention put in place to ensure that the poor benefit from the National Health Insurance. One of them is the free maternal health care program he just mentioned, and the other one is those on the LEAP. Per the MOU signed with the ministries, all those benefiting from LEAP should automatically be registered as indigent. So we try to also assess that to see how they are going about it, and we realize that in districts where there's that kind of collaboration between social welfare and NHIS, they have been able to register all the LEAP beneficiaries. A clear example is in Jirapa district in the Upper West, where the NHIS together with the social welfare, they have developed a form so that when the social welfare man goes and identifies somebody as a LEAP beneficiary, the form is given to that person. Once he gets to the NHIS, once they take the form, they register you free. But in where this collaboration does not actually exist, most of the LEAP beneficiaries have not been registered. Now, the issue of the free maternal health care, per the policy, no pregnant woman is supposed to pay money once you have been identified as a pregnant woman. But we realize that there are a lot of illegal charges there too.
Such as?
Such as they will charge something for specimen for laboratory tests, that small bottle, and also even the testing kits are kept there, and then women are charged for. And even those on admission after delivery, Some are charged as high as 100 Ghana without a receipt.
At the hospital,
yes.
Are you aware of this?
At the hospital, you mean?
Yes, at the hospital level.
Let
it's prevalent in Greater Accra region.
Let me quickly say this. You see, how do you identify somebody as a pregnant woman? Obviously, it's from a test. Okay. Now, if you do not have a health insurance card and you come into my hospital for a test to enable you to go for the health insurance card, who pays for it? Definitely, you must pay for it.
But I'm not sure he's only talking about those who are now being identified as being pregnant, but people who are also pregnant who visit the hospital.
Exactly. And those who even deliver at the facility are charged some money. And even coming back to your point, if I go to a hospital with the NHIS card and a doctor asks me to go in for pregnant test, you don't have to charge me.
If you come,
the doctor has
if you come with a card.
If you come as a pregnant person, and then you want to be sure as to whether you are really
but
pregnant
you have a
or
card.
not, but you have a health insurance card. No, it means you do not even have to go through that system because you only produce your card as a pregnant woman coming for antenatal services. So I do not see the point here. But then, if you are coming fresh,
people are paying extra monies for these services, then it's a big deal.
To the hospital, you mean?
And even the other aspect of it is that even going through this whole thing and it's time for them to deliver, there are certain items that are requested that the pregnant woman produce. The last time I checked in one of the hospitals in Upper West, there were 12 items that are. When I quantify it, it runs to over 600 Ghana cedis. The question is, yes, some of the items.
Some of the things are personal that you have to bring along from home.
Yeah, but the question is, if you are asked to produce it and you are given a list, I'm looking at the rural woman, somebody at the village level, and then the woman should bring this list to the husband, that these are the things that I need. How many of us can afford?
But that's difficult because I've gone through it. I've gone through it, so I know what you mean.
So for instance,
like the disinfectants and things like that, you can't get from the hospital.
Exactly.
So you definitely must buy and bring along.
Exactly. That is the point. But the fact is that those of us in the rural areas, our women there, how many of them can afford those items? So it's not surprising. If you look at the health insurance data, the Ghana Health Service data, you see high antenatal attendance, but that is not translating to supervised delivery. Do you know why? Because when he present that list, and husband will say, "Oh, me, I don't have money to buy all these things, so it's better you come home and deliver." So the woman will attend the antenatal, all right, but when it comes to time of delivery, because the man cannot afford to buy those items, the woman is forced to deliver, which is even dangerous.
That's a very important point.
That is
you see, like what he's saying, you see, I think that giving a list to a pregnant woman to provide prior to delivery, it's legitimate, it's right, okay? Because these are things that are not covered under the National Health Insurance.
But I think what he's saying is we should care about the backgrounds where these people are coming from, because not everybody can afford to provide the list that is legitimate, by the way.
Very good. So in this case, what do? Do we also have to bring this onto the health insurance scheme? The answer
what do you think?
The answer is no, we cannot. Because, you see, presently, I am not actually speaking for National Health Insurance, but I'm speaking as a Ghanaian, looking at the sustainability of the National Health Insurance scheme. Okay?
Do you also care about the people who are really poor?
Yeah, we do. We do. You see, there are hospitals in this country, sometimes when people come, they deliver, they ask them to go without necessarily taking money from them. I know of a hospital at Aplau, I don't know, that is Central Aplau, for example. There are times when people get there, okay, do all manners of things. When they deliver, they do not have money. The doctor will tell you, you can go.
Do we know how these hospitals are managing, how they're surviving, how they, going through? Is it having a toll on them, for instance? Is it something that they can carry out and keep doing without any support? You
see, doctors have a serious oath to see to the life of ordinary person in this country, no matter what the circumstance. So there are instances when you get to the hospital, you realize that, look, this person, no matter what the case, he cannot provide this. But if he doesn't provide such a thing, definitely the person's life is at stake. So what do you do as a doctor? Definitely you have to find a way to ensure that that person's life is saved, irrespective of where the person is coming from. Okay, these are some of the difficulties the hospitals go through in their.
But you don't think that for those who are identified as really poor, the list should not be covered?
Yeah, the list, you see, for me, the list should not be covered by the
Okay.
National Health Insurance.
All
I
right.
might say that with all certainty. It
Okay.
shouldn't be covered. You see, the husbands should be able to provide some of these things. Because if we should be putting all this onto the health insurance scheme, I'm sure we will not get anywhere.
Okay.
We will
So,
not
you
get
know,
anywhere.
recently we had a conversation about cancer because, you know, there was the awareness month in October, particularly breast cancer. And then, you know, we realized that a lot of things are not covered by the card,
Yeah.
which is supposed to,
Yeah.
you know, be
Yeah.
the relief when you have a disease that you're not expecting, things that are expensive. That's when the card should really be of help.
Good.
Is there a conversation around expanding what it covers?
Yes, it is. Presently, I think that the president of Ghana, John Ivasatamil, sorry,
The President Mahama. you mean?
Mahama, right, sorry about that, has actually sanctioned the review of the whole health insurance scheme in the country. And I think that they begin to look at inclusion of some of these things that you have mentioned and then exclusion of some existing positions. So I think by and large, by the time the review is done, it's going to give us a complete overhaul of the entire the health insurance system that will translate into the health delivery system in this whole country, including the public health as well. So by and large, I am pretty sure that if this review process is ended, some of these things will be included, especially the cancer, as you are mentioning.
But do we need a bigger review session? Because some of the things we know already. Do we have to set up a committee now to look at?
Yes.
As we speak, how effective is the NHIS?
This is a serious statement, question that you have put. The effectiveness of the health insurance scheme on the ground today, as compared to some years back, I think is better.
Better in what sense?
Better in terms of management style. That one is a must. And then the level of communicating to the providers is better as I speak. Now, we're also looking at...
How about the end user?
The end user, that is the card bearers.
The patient who's gone to the hospital with a card.
Yes, they also getting the services.
Is it effective?
Yes, because we at the hospital level, what we are doing is we're looking at the health and the life of ordinary Ghanaians. So we try as much as possible to ensure that we provide the quality health services to the National Health Insurance as an institution.
I'll ask you the same question, perhaps, you know, finally.
Is it
effective?
Yeah.
Was that part of the research?
Well, we didn't look at that.
Okay, the effectiveness of it today.
But what we also find out in our research was the fact that most of the drugs are not even in the hospital, in the facilities. So that if you go and you ask to go and buy, you have to go out and buy the drugs.
Yeah.
And even in some districts, normally what happens is that with the bigger towns, there are some accredited facilities. Even if you are asked to buy, you can take it there for them to get the drug free.
That's true.
But what about the rural areas where we don't have some of these accredited facilities?
Yeah.
Then it becomes serious.
Let's-
And even where the person is going to get the drug is an issue. Now we know there's a lot of fake drug in the system. So if I have to go outside the facility, how do I determine whether this drug is a fake drug?
We have to wrap up, but tell us, because you're launching this today.
Yes. Yeah, we are launching it at Stepri, at a CRS, behind Golden Tulip, at 9 o'clock.
All right.
So we are expecting the media.
Wouldn't that be CSIR?
Yeah, Council for Scientific and
Okay.
Industrial Research.
All right.
I would want to say that I want to use this opportunity to commend St. Ghana for the kind of work they are doing in the health delivery system. That is to say that such civil society groups, organizations are needed so much, because when we come to policy implementation in this country, somebody must be at the tip of the implementers of the policy to the extent that they do what is appropriate under the circumstance. So looking through at the report from the St. Ghana, I would want to say that kudos, and you have done marvelously well. We will want to encourage more civil society groups to come up with things like this so that
Is there funding? When they get the funding.
Yes, so I also want to appeal to
But
the donor agencies to come to their
Yeah.
aid and make funds available to enable them come up with these reports
Sure.
so that we all know where we are going.
Okay.
Because otherwise, some of these revelations will not be made available to ordinary Ghanaians.
But do
to
you
know.
see policies being made based on some of these research, some of these revelations? Do we consider?
Yes,
That's also another question
Yes,
to ask.
I had opportunity to read their previous report. Now, when I look at the current situations of the health insurance, I realize that some of their recommendations had been taken on board.
Okay.
So I think by and large, Sen Ghana is doing what is expected, and we want to encourage them to continue.
There's a message here that says, I know Togolese who have the NHIS card and always in Ghana for healthcare. Don't know how true that is.
It is true.
It's true.
It is true. There are Togolese, you see, who are on the health insurance list in
Is
this
that
country.
legal?
Yes, it is legal.
Okay.
It is legal.
So that's
once the person is a resident in Ghana, he pays the premium expected. Of course, he has the right.
So I guess the problem is living in Togo, not residents in Ghana, and coming to get the
If you are
healthcare here. That's where the problem is.
So I don't know that if the test is saying that somebody is living in Togo and coming to Ghana for health services. In that case, I want to say it is wrong.
Okay.
But if the person is living right here in Ghana, he has the right to have the health insurance card.
Okay. All right. I want to say thank you to you. Thank you so much for your time. That's Mr. Frank Toblu, Executive Director of the Health Insurance Service Providers Association, and also Mr. Adamu Mokaila is Program Officer at SEND. I was going to say we can have time and then talk about the issues of the providers. But the providers, unfortunately, don't like talking about their matters. I don't know why. There's some politics in there, isn't it? Okay, but thank you so much for being here.
Thank you very much,
Thank you so much for being here today.
Thank you.
Stay with us. We've got talk coming your way here on the show. This is the AM Show.